We're very lucky to have Andrea Witte here with us tonight. I first came across her on the HOPE Steering Committee and the HOPE presentations, which are a couple of times a month. And she's presented some of her slideshows there. If you go to her website, Connects the Dots, there's many slideshows on a lot of different things. Andrea was 25 years in the graphic design business. She had her own individual health insurance that premiums were jacking up, and she was getting jacked around by her insurance company. So she decided to focus attention on making healthcare, the problems with our healthcare system and how it compares to other countries and what a good healthcare system would look like, one of her main goals. So on her website, she has, I think, 3 or 4 different slideshows on healthcare. She's got them on economics. The idea is to break things down so that the average person, unlike us, of course, we're not average people, but the average person that will help us understand what the problems are and what the potential solutions are. So, and also we can use the slides. You can get them off her website. We can use these slides in our own presentations. And you'll see from her slides, there's a whole lot of information there that even if we're not doing a presentation, it's worth our while to go look through these slides. There's always references of where the information came from. And I think Andrea just updated the slides that we're going to see tonight within the last few days.
Yep, I added a few new ones, yep.
So anyway, take it away.
Okay, well, thank you everyone for the opportunity. And despite some noteworthy improvements for millions of Americans, the truth is the ACA never had a mechanism to get to universal insurance coverage, much less universal health care. Even without the GOP sabotage, the ACA was always going to leave tens of millions of Americans uninsured and many more underinsured. Because it was just another patch on a dysfunctional crazy quilt, the ACA could not control skyrocketing costs or the rapacious greed in the system and was doomed to stall out. Tonight, I'll show how trying to build on the ACA is a failed strategy. It's bad policy and it's bad politics. Then we'll look at why we must also eliminate, not expand, the for-profit middleman known as Medicare Advantage, as well as avoid public option poison pills. Oops, let me see what we... Okay, there we go. The U.S. has kludged together versions of many different foreign healthcare systems into a costly, confusing, and often cruel crazy quilt. Unlike other civilized countries, however, America allows profiteering and price gouging by big insurance, big pharma, and big hospital, rendering healthcare unaffordable and inaccessible to tens of millions of Americans. For those who fail their wallet biopsy, their options are pay out of pocket and possibly go bankrupt, pray, stay sick, or die. Over the last decade, the Affordable Care Act did get 21 million more Americans insured, mainly by expanding Medicaid, shown in green, as well as providing subsidies and patient protections to people in the non-group insurance market, shown in orange. Despite these very important gains, however, in 2017, the ACA still left more than 28 million completely uninsured, shown in red. Last year's University of Massachusetts Perry study also found that over a quarter of insured Americans, about 86 million, are actually underinsured, with deductibles and copays that are too high, so they forgo needed care. The ACA was a complicated patch on an already complicated kludge. It did little to control actual prices and has been vulnerable to constant sabotage from Republicans and disgruntled insurance CEOs. According to a recent Gallup poll, the number of adults without health insurance rose by nearly 3%. That's 7 million more people since 2016. Almost half of them cannot access health insurance, either because they live in a state that did not expand Medicaid, they are excluded immigrants, or they earn too much for a subsidy but too little to afford the premiums. In fact, the cost of health insurance is the biggest reason why people do not purchase it. This chart maps the complicated, inefficient terrain of our current healthcare financing system. It's a Rube Goldberg nightmare designed to guarantee the profits of the few, not healthcare for all. While 2/3 of spending is already government finance when you factor in all the tax subsidies, many of those taxpayer dollars are funneled through rapacious for-profit middlemen. As you can see here, and we're going to talk about later, the Medicare Advantage plans and the drug plans, and also many of the Medicaid plans are run through private insurance HMOs. As you can see here, the ACA was just another patch adding to the complexity. There are only two ways to try to cover more people under the Affordable Care Act. One, expand Medicaid in states that have refused to do that, but the Supreme Court ruled that the federal government cannot force them to do so. Or two, funnel more federal money to private insurers through various mechanisms so people can afford their overpriced products. This is basically Joe Biden's plan. Currently, households are expected to contribute between 2 and 10% of their income on the premium for a mid-level silver plan before the federal tax subsidy kicks in. These silver plans have average deductibles of $3,900 for an individual and $8,000 for a family. Hardly affordable when 2/3 of Americans cannot cover a $1,000 emergency. And the income cutoff for subsidies is a hard cliff, meaning if you make even $1 over the $48,500 for an individual or $100,000 for a family of 4, you get absolutely no help with the outrageous premiums. Defenders of the ACA can fight the GOP to cover a few more people, but it is an expensive path for marginal gains. Sadly, further subsidies will never result in universal coverage or end our complicated and expensive healthcare system. Such tinkering with the current system does not solve the problems people continue to have getting care. Because the Supreme Court ruled that states could opt out of the Medicaid expansion, the GOP continues 6 years later to block millions from getting health care in their states. Voters in red state Idaho, Utah, and Nebraska approved the expansion by ballot measure last year, but the Republican-controlled legislature and/or governor are thwarting its implementation, just as the governor of Maine did for 2 years before he was finally replaced by a Democrat. Not to mention, many red states that approved the expansion, as in my home state of Arizona, are undermining it with work requirements and more paperwork for enrollees. We are now going backwards with folks losing their Medicaid coverage. This was always a weakness of the ACA, which was too vulnerable to sabotage by red state politicians and other insurance CEOs. So when Speaker Pelosi says she wants to work with Republicans to expand on the ACA by getting more states to accept the Medicaid expansion, she is the one living in fantasy land. In the non-group insurance market, the Affordable Care Act shifted some of the cost of private insurance to the federal government, which helped millions of people, but did little to control overall prices that had been skyrocketing for years. As a self-employed graphic designer who had been buying my own individual plans for 2 decades, that yellow line you see is me. I had high hopes for the ACA when the marketplace first opened in Pima County, Arizona, with, get this, 119 plans offered by 8 insurers. By 2017, however, we were down to just 1 insurer and 2 plans. Retail premiums soared. While a couple of insurers re-entered the marketplace in 2019, the competition did not reduce premiums. As I mentioned earlier, while folks below 400% of federal poverty level are protected against these rate hikes, there's no such protection for middle-class families that make too much to qualify for tax credits. And the deductibles and cost sharing are still way too high for most families. Even worse, the Republicans' recent gutting of the individual mandate and resulting court challenges threaten to undermine the ACA's protection for pre-existing conditions. Face it, a decade after passage, and we're going backwards. Nor did the ACA do much to control skyrocketing premiums on employer-sponsored plans. The average premium for family coverage is $20,600 this year, more than triple the premium in 1999. The worker share jumped from $1,500 to $6,000, almost 4 times higher. Average total health spending, including out-of-pocket, was over $28,000. Of course, employers ultimately pass their portion on to employees by keeping wages flat. A modest Medicare for All payroll tax would get this burden off the backs of employers and cost them far less. So when corporate Democrats like Speaker Pelosi argue that Americans like their employer-based health insurance, what exactly do they like? The skyrocketing premiums, the exorbitant cost sharing, the lost wages, the surprise balance bills from out-of-network providers, or the constant fear of losing their health insurance if they lose or change jobs? Fragmentation with so many private payers means they lack the negotiating clout to get the lowest prices. A one-day hospital stay averages $5,200 in the US, but it's only $2,100 in New Zealand and only $765 in Australia. Need a coronary bypass? It averages more than $78,000 in the US compared to just $24,000 in the UK. Or how about the hepatitis C drug Sovaldi that retails in the US for $1,000 per daily pill? That totals $84,000 for the 12-week course of treatment, while there is a high-quality generic version available in India for just $4 a pill. And let's not forget Mylan's EpiPen that commands $600 in the US, but only $100 in Canada. How much Americans actually pay out of pocket on these inflated prices depends on whether you have insurance or your particular plan's details. The ACA did nothing to address this rapacious behavior, which is driving up healthcare costs, bankrupting families, and creating barriers to needed care. That's because the ACA is based on the misguided notion that healthcare is a marketplace. In his famous 2013 article, The Bitter Pill: Why Medical Bills Are Killing Us, investigative reporter Stephen Brill exposes the widespread medical price gouging that goes on regularly in the US. It's a complete seller's market with no pricing transparency and no leverage for buyers who are often facing life and death decisions in crisis. We are no match for the evil charge master, a completely irrational document of insanely high prices that each hospital maintains but denies having it, as if it were an eccentric uncle living in the attic. Even if you have time to try to get advanced pricing on a procedure, I have found that many health providers, especially hospitals, push back and sometimes get downright hostile about giving you that information. They protect those billing codes as if they were the nuclear launch codes or Coca-Cola's secret formula. If you lack insurance or accidentally go out of network, you'll get smacked with the insane chargemaster prices. And beware of RAPLs, which is an acronym for out-of-network radiologists, anesthesiologists, pathologists, labs, emergency docs, and specialists that often spring up at in-network facilities. Look at this example of my husband's 3-hour emergency room visit for treatment of a kidney stone. Even with the ACA, an uninsured or out-of-network patient would have little leverage against the $14,000 chargemaster price. While traditional Medicare negotiated that price down to less than $1,200. In this case, Medicare paid $936, my husband's supplement paid another $188, and he paid a $50 ER copay. With National Improved Medicare for All, cost sharing is eliminated entirely, so the private supplement and copay would become obsolete. So despite some worthwhile improvements under the Affordable Care Act, our current healthcare crazy quilt is still hopelessly complex, costly, and cruel. Here's a snapshot of the staggering numbers to share with those defenders of American exceptionalism. We spend 18% of our economy on healthcare, which was $3.6 trillion in 2018. That averages to over $11,000 per person, more than twice the average of other developed countries. The estimated cost over the next decade is a whopping $50 trillion. The average employer family plan, as we saw, has an annual premium of over $20,000, with the worker directly paying a 29% share. There's over $500 billion of bureaucratic waste shouldered by providers and patients due to the complex labyrinth of so many different insurance plans. Yet even after all that spending, we still leave 31 million uninsured and 86 million more underinsured. That results in about 28,000 deaths per year due to delayed care from lack of insurance, roughly 1 in 1,000 uninsured. 530,000 bankruptcies per year are due at least in part to medical bills and illness, which accounts for 2/3 of all bankruptcies. Sadly, that statistic has remained constant even after passage of the ACA. In short, this is the unsustainable system we cannot afford to continue. Any cost of a new system like National Improved Medicare for All must be evaluated in comparison to these economically and morally indefensible numbers. By contrast, Medicare for All gets everyone covered with better benefits and no cost sharing. Rather than allowing the for-profit insurance middleman to cherry-pick the young and healthy and lemon drop the old and sick into public programs, everyone gets covered in the same risk pool. National Improved Medicare for All also gets the insurance burden off the back of businesses so they can compete on an even playing field nationally and internationally. And it frees workers and budding entrepreneurs from job lock for health insurance benefits. And instead of having the pseudo choice among rapacious insurance companies, who really likes their insurance companies or likes open enrollment? Americans will have more choice of what they truly care about, choice of doctors and hospitals throughout the entire country. Currently, 96% of doctors in nearly every hospital are in-network for traditional Medicare. That number will only increase once Medicare is the only insurance payer. Whatever providers might sacrifice in lower reimbursement rates overall will be more than offset by reduction in overhead, increase in billable hours, and less burnout. Not surprisingly then, 2/3 of doctors now support single payer. So in stark contrast to that Rube Goldberg nightmare perpetuated by the ACA that we saw earlier, here's how a Medicare for All single-payer financing system maps out. Ah, so simple and elegant. New federal taxes would replace the huge amount of money already being inefficiently spent by families, businesses, and state and local governments on private insurance premiums and out-of-pocket costs. Now, presumably, there would still be a small amount of elective or cosmetic procedures and over-the-counter meds and vitamins, about 3% of total healthcare spending, that will continue to be paid directly by households. All that efficiency and bargaining power from a single-payer system would save at least $800 billion per year. We'll use a big chunk of that, about $400 billion, to improve existing Medicare and expand it to everyone, leaving a net savings of about $400 billion or 10% compared to our current system. Because half measures and tinkering are just another patch on our current healthcare crazy quilt, they forego the administrative savings and negotiating clout that make it easy to fund universal healthcare with comprehensive benefits and no cost sharing. So ironically, incrementalism ends up being more expensive than Medicare for All and way less bang for the buck. And by the way, if you like delving into the arithmetic like I do, I have an entire presentation entitled M for A Math, but how are you going to pay for it? Where I walk through all the cost studies and dispel the apple oranges comparisons that have run amok. And basically, just to give you a little hint, the naysayers and the people in corporate media, they want to focus on the yellow getting larger, the added costs to the federal government, and we want to focus on the important point that the total length of the bar gets shorter. So that's where the confusion comes in. But more important than bringing down the total cost, the burden of healthcare costs will be more fairly distributed. Most families will see big savings under National Improved Medicare for All. A middle-class household will net save between $7,000 and $12,000 compared to what they are currently spending on healthcare. The top 5% will pay more in our progressive financing system, but we're still only clawing back a fraction of what they used to pay before the great trickle-down tax con began 4 decades ago. Now, this is what I think Bernie was trying to get across in the debate last night, and to some extent Elizabeth Warren, which is that, and so we see here that we already have a private tax in the form of premiums, deductibles, and copay. So as I mentioned, according to the 2018 Milliman Medical Index, for the typical family of 4 with employer-sponsored health insurance, the total cost is over $28,000 per year, with the employer contributing nearly $16,000 and the employee spending over $12,000, $7,700 in premium contribution and $4,700 in additional out-of-pocket spending. We should refer to that as a private tax. Bernie's Medicare for All financing proposal would cut that by 2/3 for the median family of 4 with $95,000 in income, saving about $18,000. The nearly $9,000 saved on the employer's side should be returned to the worker in the form of higher wages or other benefits because it is part of their compensation package. In short, public taxes go up by far less than private taxes go down. Another trick the corporate Democrats like Speaker Pelosi have been playing is pointing to the gaps in cost sharing in existing Medicare and saying how the ACA's coverage is better, especially because people are protected with a max out-of-pocket ceiling, which has never been the case in Medicare. While that is indeed a defect in existing Medicare, Speaker Pelosi knows full well that improving existing Medicare to get rid of its many gaps and cost sharing has always been an integral part of the Medicare for All movement and every bill proposed. Heck, the word improved is right there in the title of the bills. Speaker Pelosi is either not the master legislator she claims to be, or more likely, she is gaslighting us. According to Representative Jayapal's H.R. 1384 Medicare for All Act, the comprehensive list of benefits shown here will be covered with no deductibles, copays, or coinsurance. In other words, health care will be free at point of use. Those benefits include hospital and doctor services, both inpatient and outpatient, emergency services and transportation, prescription drugs and medical devices, lab work, preventive screenings, long-term care, mental health and substance abuse treatment, physical therapy, dental, vision, hearing, and reproductive care. So don't let anyone tell you that any current plan has better coverage. Likewise, the incrementalists are gaslighting us when they say people will lose their benefits under the ACA. No, all those ACA benefits that people like, including pre-existing condition protection, guaranteed benefits, no lifetime or annual caps, free preventive services, they all get rolled into Medicare for All and vastly improved. You even get dental, vision, and long-term care coverage, which is not included in ACA plans except some dental for children. And NIMA does away with the parts people hate, including premiums, deductibles, copays, limited networks, surprise medical bills, and fighting with greedy insurance companies. So now we must also do away with the useless for-profit middleman known as Medicare Advantage, not expand it as Senator Kamala Harris wants to do in her latest plan. I call Advantage plans the charter schools of Medicare because taxpayer dollars, $233 billion in 2018 alone, are funneled through these profiteers who are adept at cherry-picking the healthy, lemon-dropping the sick, and defrauding the government out of tens of billions every year with little accountability. Currently, 1/3 of Medicare enrollees get seduced by the zero or low monthly premium and some extra bells and whistles to join an Advantage plan. If they get sick, however, many come to regret that fateful decision. So now many folks are confused about the difference between traditional Medicare and Medicare Advantage. So let's break it down. And part of the confusion is the same companies that sell Advantage plans also sell those supplement Medigap plans. So that's where it gets confusing. Since 2003, when the privatization of Medicare really ramped up, there have been two basic pathways for seniors to get Medicare benefits. With traditional Medicare, also known as fee-for-service, the federal government is the primary insurer and pays the hospitals and doctors directly. To protect against huge out-of-pocket costs, however, seniors must either get supplemental insurance through a former employer or purchase a Medigap plan, a prescription Part D plan, a drug plan, and a dental plan. To avoid those extra monthly premiums that can total, $250, $300, 22 million instead opt for a Medicare Advantage plan, in which the federal government pays a for-profit private company a capitated amount, on average about $950 per month, to be the insurer. Even more if they upscore the enrollee as sicker. The enrollee still pays the $136 per month Part B premium to the federal government, but only a zero to low premium for the Advantage plan. Often prescription drugs are included, as well as some extra perks like vision, some limited dental, and a gym membership. Now, here comes the downside. First, instead of being able to choose from nearly any doctor or hospital in the entire country, you are now restricted to a much narrower, ever-changing provider network. If your doctor leaves the plan, you must switch doctors or wait to switch Advantage plans during open enrollment. That happened to 6,000 Blue Cross Advantage customers in Pima County, Arizona last year when the plan lost their contract with 100 primary care providers. So my husband's on traditional Medicare, and we kept seeing signs saying that as of January 1st, they were no longer going to be accepting the Blue Cross Advantage. But they were still, of course, going to be taking traditional Medicare, so there was no problem for my husband. Second, what you save in monthly premiums may be more than eaten up in out-of-pocket spending, especially if you get really sick. Advantage plans have high cost sharing, up to $6,700 per year for in-network hospital and doctor services alone, as well as a much greater danger of surprise out-of-network bills. And because Advantage insurers lose money on the chronically ill, they have devised all kinds of sneaky schemes to force you out via prior authorizations, high copays, denials, restricted specialist networks, and restricted drug formularies. And perhaps worst of all, while you can return to traditional Medicare during open enrollment, you may be forever locked out of getting a Medigap plan because they can deny for health status after the initial enrollment opportunity. As we have learned from Medicare Advantage, the Medicare Advantage experience, the public option would become a de facto high-risk pool as private insurers game the system by cherry-picking the healthy and lemon-dropping the sick, most expensive, onto the public plan. It is not a path to single payer. Rather, as just another patch on our healthcare crazy quilt, public option proposals that go by many names, sometimes co-opting the Medicare for All name or versions of it, but public option proposals forego most of that $800 billion in annual savings from the simplified administration and lower prices under single payer. For these reasons, premiums and cost sharing will still be too high for many Americans, thereby undermining the public plan. So now Dr. Adam Gaffney of PNHP, as I'm sure you all know him, he eloquently explains why we don't need or want private health insurance in the mix. Quote, "The only way to make room for a significant role for private insurance in the American context is to make the public system paltrier or skimpier, to impose onerous copays and deductibles, or to let the rich preferentially displace working class people from hospital beds and doctors' offices. But it doesn't seem to make sense to punch holes in your own floor just to create work for a carpenter. That is particularly true if your floor is your health care and your carpenter is an extractive insurance giant." I thought that was just a brilliant metaphor that I've shared with many people. So finally, let me end with my favorite healthcare quote from former US Representative and bold progressive Alan Grayson, who aptly points out the problem with the incrementalist approach. "For God's sake, every single other industrialized country in the entire world has universal health care. Why can't we? How many more people have to die? How many more sacrifices on the altar of almighty greed? Any healthcare system that denies necessary care on the basis of wealth is evil. It doesn't matter how you micromanage it or tinker with it. It's evil." End of story. Thank you, everyone.
I don't, are those slides available, David? Yeah, they're
Yeah.
Yes, so everything's available at my website, which you're seeing here, connectthedotsusa.com. You can also do connectthedotslady.com. And you'll see PDFs. And sometimes I'm behind getting the PDFs updated because I wait until I have a lot of the individual slides, but there are also individual JPEGs in the JPEG section. And then those I try to update as I get each one done. And you can grab those JPEGs and share on social media or incorporate them in your own presentation. And then I also, you can follow me on Facebook and Twitter. And I also have a YouTube channel where I post these regularly. So and they're all free to use. And so this particular presentation, I just uploaded it today under the Medicare for All section. So, and I also have a video of an earlier version of this.
Questions?
Yeah, I had one question. So you had that infographic on the amount of savings under the Medicare for All plan. I think it was, you went from 14 or 28,000 down to about 9,000 or so. And that was under the Sanders plan, correct? Do you know if any similar data can be found under the Jayapal bill?
No, she hasn't put forth any kind of financing proposal. So Bernie kind of did it in a side white paper. It's not actually part of the bill. He had put together just a menu of options that would that would raise about 16 trillion in revenue. So I just kind of took the two that affected middle class, because most of them affect high income earners and wealthy people and corporations and things like that. So I picked the main ones that would affect middle class and regular people would be a 4% income tax after the first 29,000 on a family of 4 and a 7.5% payroll tax on employers. So again, that's what I use to sort of calculate and do that side by side. But I don't think anyone else, I mean, there was originally HR 676 didn't specifically have a specific plan, but Gerald Friedman had put together some numbers that people would use that was somewhat similar to Bernie's.
Okay, Jack?
What's your make on the difference between Bernie and Pramela's plans?
So, Jayapal, Pramela's plan is definitely the better one. I think the biggest downside of her plan is just the 2-year rollout. We need to try to get that to 1 year. I mean, we need to get this thing implemented as quick as possible so people see the benefits. Bernie's plan, and this wasn't part of his 2016 plan. I think a lot of the problems with Bernie's plan got shoved in there by people like Kirsten Gillibrand, because he was trying to get co-sponsors. So I think he let some of these corporate Dems sneak some stuff in there, which I don't think he's really wedded to. So my biggest problem with it is the 4-year rollout, because it's not even like Jayapal, where it's actually improved Medicare for all in the first year for people of certain ages, and then the second year, everyone. Bernie does this complicated where you're basically opening up Medicare Advantage. You're sort of improving on existing Medicare by putting a max out of pocket. You're including some dental, and then you're lowering the age, but you're allowing people to continue to buy Advantage plans all the way through the 4 years. So that's one of the big drawbacks, and the 4 years is way too long. Of course, the steering committee with Hope, they've discussed a lot that Bernie leaves in all of these value-based payment systems, the the accountable care organizations, and all that create a lot of paperwork, and so that they cut in on a lot of that administrative savings, at least some of it. Another thing with Bernie's bill is not a big deal, but he does have this $200 copayment on brand name drugs, maximum of $200 for the year. So I don't even know why he has it in there, because it doesn't raise that much money. Oh, and then a big part of Bernie's bill is he does not include institutional long-term care. So if you recall his 2017 version, he left long-term care out entirely. Meant it stays at the state level, which means it's under Medicaid, and you have to do a spend down of your assets in order to qualify. So he did improve it in his 2019 by bringing in home health and community-based long-term care into Medicare for all, and it would be the federal program. But he still left institutional long-term care at the state level. So that's a big problem. But I would say that those are probably the 4 main problems that we discuss a lot in the steering committee.
Okay, I have a question about how contracts are, how they trickle down. Say the federal government, Medicare contracts with certain providers, and do those say, is there a pyramidal form? That is, Medicare contracts with, let's say, United Healthcare, and then United Healthcare may subcontract to other providers?
You mean how the Advantage plans work? Is that?
Oh, I'm really trying to follow the money.
Okay, so with you, you're on traditional Medicare. So I'll use my husband as an example. He has traditional Medicare. So basically, when the claim is filed, it goes to the federal government. It goes to CMS first. They determine what the amount that's allowed to be charged, because every doctor I've ever encountered, every hospital is basically accepts assignment, is in network. Okay, so then they pay their portion, and then they send that to the supplement, which he has an AARP United Healthcare Medigap plan, a Plan N, okay, which covers all the cost sharing gaps except for the $185 Part B deductible, right? So then what Medicare doesn't pay, they make all the determinations, they automatically send that to the GAP, the supplement plan, and then the plan picks up the part that they pay that directly to the doctor. So they kind of function as a secondary insurance. And then what's the left, like the $50 ER copay or the $185 Part B deductible, then that the provider, the doctor, then ultimately bills my husband that. So that's how it works with the traditional Medicare plus the supplement. The federal government is your primary insurer for Part A and B. And then the supplement serves as your secondary insurer. Okay, and the great thing about the supplements are any doctor that's in network or accepts assignment for traditional Medicare also has to accept and process the claim with the supplement. So that works out great. So you don't lose any doctors that way. Now the way Advantage plans work is you sign up for one of these Advantage plans, and there's a complicated bid process that I don't even know all the ins and outs of it, that these companies do in every county, in every region. They bid on what they're going to, what they're going to take per month to be the Advantage insurer, right? And then once those things are agreed upon, when you go and sign up for an Advantage plan, then the federal government pays that insurance company. It's no longer paying a doctor or hospital directly. It then pays the insurance company a capitated set amount of money per month. Like I said, on average, $950 per month. So they give that check to the insurance company. Now that insurance company is your insurer. They make money if they can keep your spending under $950. They lose money if you spend more than that. So you see where the incentives are.
Yeah.
So does that make it at all clear?
Yes. I currently am a member of Kaiser Permanente, and I'm in an Advantage plan there. And I believe Kaiser Permanente is a nonprofit. So I think there's very little difference in terms of for-profit insurance companies and the managed care companies that are quote unquote nonprofit. But I don't think there's any difference.
Yeah, I've been reading stuff that it seems to be just a difference in terminology, that they
Right.
do the same kind of behavior of trying to, basically figuring out ways. Like one of the things Advantage plans will do when they market is they'll go to fitness centers. They'll market the gym membership, figuring healthier people will be at fitness centers. And then they won't contract with very many, say, diabetes specialists. So then they have very limited networks. And this is the scheming that they do.
I see as subcontracting and subcontracting and subcontracting. I really want to clarify for exactly how all of the money flows and through whom, because I think there must be dozens of contractors, subcontractors.
Yeah, the Advantage plan system is infinitely complicated. And even recently, there's been some articles that CMS, they've done these limited audits and they see all this fraud. And then they can't even claw back the money when they see obvious fraud that United Healthcare is doing, because United Healthcare sues and says, no, because that was based on like a representative audit, so you can't prove. I mean, and then they don't have transparency about their numbers because they say it's proprietary. So there's just all this fraud going on, at least tens of billions every year. Because another thing that they'll do is if they say that you're sicker, they can get more than the $950 per month. So they have an incentive then to upcode you as saying you're sicker than you are, because you're not actually going to use more services, but then they can get more per month. And that was a big trend a few years ago when the ACA tried to crack down on those overpayments. What they did is they discovered, well, we can do this. And there was a big push to do free home health visits. We'll come to your house, we'll do these free home health visits. And the seniors are thinking, oh, this is a nice perk. But what they were doing was they were trying to figure out a way to upcode them, upscore them to get more money. So they'll never stop doing it. It'll be like playing whack-a-mole. Every time you try to come up with a way to regulate them, they will come up with a way to get around it. And they're not necessary. If we get rid of the gaps in existing Medicare, which is the point, then we don't have any holes, we don't need them. I mean, one of the things you could do, if you put a max out of pocket on Medicare, which surprisingly it has never had, every other insurance plan, even though the max out of pocket might be high, if you put a max out of pocket on Medicare of say $1,000 or $1,500 a year, like my husband wouldn't buy a supplement. We would just go, well, if we have to, that's cheaper than paying the premiums every month. If we hit the max, we're still saved money. And then there might be years where we don't even hit the max. So that's one of the biggest problems with Medicare. There was never a max out of pocket put in. So, any other questions?
Yes, I noticed that you mentioned calling the tax that would be levied to support Medicare for all, or rather the premium, calling premiums a private tax. I was wondering if you could go the other way and call the tax a premium.
Right. So yeah, you could call the 4% income tax the premium, the payroll tax. We're used to just calling payroll, but I think Bernie sometimes even in that white paper might refer to that as like an income premium. Yeah, you could go that way. But this whole discussion with the corporate media and these debates, and they asked the same question. If you watched last night, I think it was the exact same wording as the last debate with, you're going to raise middle class taxes. Will you admit that you're going to raise middle class taxes? And of course, Elizabeth Warren is trying to explain, yeah, but the costs go down for almost everybody. That's the important thing. You end up with more money in your pocket. Who cares what you call it? But they're obsessed. You know, they just want that soundbite that you're going to increase taxes.
Yeah, well, as Elizabeth Warren showed, even pretty progressive people are allergic to saying the word tax.
Yeah.
That's why maybe we should say premium.
Yeah, and so I was saying yesterday with a friend that Bernie needs to sit down and write out, they need to focus group this, write out the answer to that question, come up with the exact wording. I mean, maybe you just say something, look, people are going to end up with better health care and on $10,000 more in their pocket. They're going to, it's, you know, something simple like that people can understand. Because it really is the silliest argument. That like they only want to tell half the story. They only want to tell the part about the taxes going up, not the premiums and cost sharing going down by way more. And it's the same thing on the macro level. They constantly want to focus on the added costs of the federal government. That's the 32 trillion number. They keep referring that to the cost when in the studies, it's just the added cost to the federal government. And they don't want you to see that total spending goes down. Because that's the important one. We're just shifting things around.
Introduce yourself real quick.
Hi, my name's Bonnie. Hi. I don't have a question, but in a comment for what you're saying about the presidential debates.
Mm-hmm.
In some ways, I just wish they would hold up your slide that says families and businesses will save big, and show that slide versus talk.
Yeah.
And say, look, it's here on this slide. This is what's going to happen, because they keep getting tripped up and I don't know, kind of put on the spot to answer yes or no, and it's not a yes or no question. It's, you look at when people decide on what kind of health care plan to purchase, they're looking at the overall bottom number of how much they're going to pay and what will be saved. And it doesn't, and that, I think it would be perfect just to show your slide.
Right.
Can we suggest that to them?
Yeah, exactly. We need to bring these debates into the 21st century with a little IT and audio visual, right? I mean, sometimes a picture speaks 1,000 words, right?
Well, true, because you can't, I mean, if people could see this, it would be a great advertisement for the people of the United States.
Yeah.
Yeah. For your question.
I agree. Good point.
Hi, Andrea, my name's Kathleen Randall. I'm kind of interested in the small business person. I recognize that employers have been working on trying to maximize their tax deductions, maximize their profits, and still keep good employees. And so I'm kind of wondering with us, the big guys, I'm not too sure I know about. They get so complicated and so complex. I think we could talk about them for a millennia and never get it.
Right.
But with small business, it seems to me if we focused a little bit more on that group and how Medicare for All would be advantageous to them and would still provide them with really high quality employee opportunities with low cost and adequate deductions to make it worth their while. I would really like to see a slide that played that out a little bit and to see how that might appeal to them. because I talk to a lot of small employers, and they've got lots of defenses up, oh my God, no, don't talk about insurance. It's a big bugaboo, and it's really complicated for them, and they really get caught in the middle.
Yeah.
They're often caught in the middle, and often go out of business. And we talk about medical bankruptcy. I talk about small business bankruptcy and viability.
Yeah.
And therefore, innovation and creativity. Thank
Yeah,
you.
that's a good point. And I should point out that Bernie's suggestion about the 7.5% payroll tax is only after the first 2 million in payroll. So small businesses that would exempt probably most small businesses. So, and exactly, that's a good point, that they have trouble attracting the best talent because the best talent is going to want health benefits. And a lot of small employers can't provide that, so they lose out on that. I think the movie Fix It Healthcare, I'm sure you are all aware of that movie. I haven't seen it for a while, but that's something. And then Wendell Potter just started a website with another gentleman who has been really talking about the business aspect of it. He's got sort of a mid-level business, and he spends an enormous amount on healthcare premiums for his employees. He's one of the biggest manufacturers of picture frames, the wooden picture frames and different things. So I'm trying to remember the name of the website because I just read an article about it. I'll get it to David. But if you probably Google Wendell Potter, he and that businessman started a website. And if you recall, Wendell Potter is the former Cigna marketing guy who became a whistleblower on the whole insurance industry. And so I know he's working on some framing, especially around businesses.
Was that Richard McMaster, I believe?
Yes. Yeah. So if you Google their two names, they just started a new website.
Okay.
Thank you.
But good idea. I'm going to put that on the list.
Wendell Potter's website. Tarbell.
It's called Tarbell. It's Wendell Potter's website.
Yeah, he started something with the word business in it. I think if you Google the two of them. Yeah.
BHIP. I had a question. So I wanted to get your take on the current political climate around Medicare for All. So we saw a recent Kaiser Permanente poll or family poll saying that currently nationally only 51% of Americans support Medicare for All, which is down from 57% at the beginning of 2019. And also, what's your take on what is really going to need to happen in order to garner more support in the United States? I mean, from my perspective is that we need to bolster the messaging around, why people have this fear of losing their private health insurance, because that's another debate talking point is that, who wants to eliminate private health insurance? And that scares a lot of people. But I think if we have grassroots organizing messages and educational campaigns to inform people about, really the benefits of Medicare for All, and just having a real conversation about people losing their private health insurance and getting onto a better plan is really necessary.
Yeah, very good points. Yeah, so I mean, it's common psychology that people have loss aversion, right? That you're afraid of the unknown. So part of it is make it less scary for people, and that was the whole impetus behind the single payer movement adopting the Medicare for All framing, right? Because it was originally you just called it PNHP, they just called it single payer because that's what it really was, and then somebody suggested, that that's kind of, people don't understand what single payer, it's kind of scary. So if you use the framing Medicare for All, Medicare is something people are familiar with, it's very popular. And so it was a good idea in that sense, but it was a bad idea in the sense that our existing Medicare system is actually kind of paltry compared to a lot of other countries' public plans. So I think that's why I think giving people some detail, like if they can calculate what their taxes would be and do the little math themselves and go, oh man, I could save a lot of money. Oh, I would get dental. I would get long-term care. It's taking those things that are scary and making it comfortable for people. And I think that's what our mission needs to be, because people are afraid. They don't want to jump to something unknown. They're going to stick with the devil they know. They don't really like their health insurance company. Nobody really does. And let's face it, most younger working people, they don't really interact with their insurance company that much. right? I mean, it tends to be smaller things that private insurance will usually pay for. It's when you get really sick that that you have the bad experience. So, and then to get back to the Kaiser polling, well, obviously the powers that be that make money off our current system, they are working hard at driving down the popularity of Medicare for all, right? I mean, Kaiser itself, if you look at the background, while they do some good work, and I use some of their graphs on healthcare generally, you have to be careful on the Medicare for all because they do not support. If you look at their board of directors and where they get their money, these people do not support Medicare for all. So they did that polling where, I mean, it looks like a push poll to me, where they do, well, what if you heard that Medicare would increase your taxes? And then they don't tell you the other half. What if you heard that it would endanger existing Medicare? So they just take a bunch of right-wing talking points, and then they go, oh, but we weren't saying it would do that. We were just asking the question how you would respond. And then, of course, so that is so deceitful. And then, of course, the New York Times and the corporate Dems and everybody pick up that poll and use it exactly the way Kaiser said it wasn't supposed to be used. So, so we have to try to counter that. But we can't be surprised that they weren't going to try to drive down the poll numbers.
Right, but one of the frustrating things with the current messaging is that we're seeing all these presidential candidates coming out with their own Medicare X, Medicare Advantage for all, and I think that that's really diluting the message behind our proposal, which is a single-payer Medicare for all system.
Yeah, and that's why I think you're right that we've got to say Medicare for all single payer. Because basically the way I'm seeing it now, Bernie's the only one who is talking about a true single payer who's running for president. I mean, Elizabeth Warren keeps back. She was always equivocating, and more recently she just acts like she's completely backtracking. So
I just saw a message from Kevin Zeese today that you probably saw also, that the public option is outpolling Medicare for all by 20%. And I think it's probably because, the mass media and most of the presidential candidates are saying, well, yes, the public option is where we ought to go. And it sounds public, that sounds good, but they say, well, maybe I don't have to give up my Medicare if we have a public option for some other people,
So then I think we have to tell people what they're giving up, because when it's presented that way, people are like, oh, well, if I could have the option of both, and if I don't like that one, I can jump back, kind of cover all my bases. They don't see that what you're giving up. And that's why I did that one slide at the end. You have to communicate to them what you're giving up is you're giving up that $800 billion in administrative savings. And that's what we used. We used half of that to pay for the dental and the long-term care and no deductibles and copays and all that stuff. So then that's how we lowered the cost of the entire system. If you don't do that, well, then you're still going to have deductibles. You're still not going to have dental. You're still not going to have. So I think we have to kind of do and you're not going to have a choice of any doctor that you want. So again, and doctors are going to still have to deal with all this paperwork and the burnout. So I think you got to show them you are losing something. It's not like, oh, well, if I'm not going to lose anything, I may as well just have that option. And so that's I think what we need to drive home.
One other thing is I saw in the paper the other day that United Healthcare eliminated from its, its network all of Houston Methodist hospital systems, and there's a whole bunch of hospitals and clinics there. So those are Medicare Advantage plans for United Healthcare. Those people are going to lose their doctors.
Mm-hmm.
So this
is the part they don't see. They
right.
see the bells and whistles. Oh, and those bells and whistles with Advantage plans, and I know if some of you are on them, please let me know. I mean, I only know from the research because my husband isn't on one of those, but it seems like the bells and whistles that they offer are kind of worth hundreds of dollars a year. Like, let's face it, vision, an eye exam and a pair of glasses, hundreds of dollars. Because if you get cataracts or that kind of thing, that's an ophthalmologist. That's already covered under Part A and Part B Medicare, probably under Part B Medicare. So, so those kind of, and then when they say dental, my understanding when I read the fine print, it says preventive dental, which that just means cleanings and x-rays. It doesn't mean crowns. It doesn't mean root canals. That's called restorative, which is where the big money, where the big expenses. So, so they suck you in with these things that are worth hundreds of dollars, and then it sounds good. Oh, I'll only have to have one card. Well, the way my husband does it with traditional Medicare, it's no big deal because he doesn't have to deal with the supplement. It all just gets automatically sent there. Yeah, he has to get a Part D, which you can only get private Part D plans because that's the way the Republicans designed it when they passed it in 2003, that it always had to go through a private plan. But what people don't realize is every year the federal government is subsidizing those private plans to the tune of about $70 billion a year. So when you're paying about $30 a month premium, the true cost of that premium is about $144 a month. Again, it's all hidden as a way to funnel money to big pharma and big insurance. So yeah, so with the public option, I think we have to communicate to people that you are losing something. That it's not like you can have your cake and eat it too. You can't have your long-term care and your no cost sharing and your public option. You've got to go with single payer.
Okay, thank you.
Margaret Walsh. The way I talk to people is Medicare for All is the greatest liberator of workers our nation has ever known. Imagine the relief to every state, county, and city government no longer having to provide a lifetime of health care to every firefighter, librarian, and their family. So I wouldn't even, include employers for any reason. Why ball and chain somebody, right? But Andrea, I can't find you on Facebook. What's your Facebook?
Oh, the best way to get to my Facebook is go to my website, connectthedotsusa.com, and then down in the lower left corner, you'll see the little icon of me, and you'll see my social media. So then you can click on Facebook, Twitter. So it's a an educational page. So it's not like a friend page. It's a so that, and then you have the YouTube channel where I put up videos too.
Thank you. And on Ralph Nader Radio, there was a guest. He's apparently written a pamphlet on Medicare for All. I don't know, but what he said is if you earn between $50,000 and $60,000 a year, your federal tax increase to cover your portion of Medicare for All would be about $1,800 a year. That's $150 a month for full dental. And I tell people this and they go, yay.
Yeah.
They're thinking about it. But the visual I'll leave them with is, there's going to be tremendous opposition. Everybody gets a nutritionist just from the big bad food companies. Yeah. And
yeah, I agree, Margaret.
I'd like to see eminent domain come in and take out McDonald's and put it in Medicare centers, and their eyes just light up. It's just a visual that we can do that. People could do something like that, and it's just what the people want anyway. So thank you.
Yeah, you're welcome. Yeah, I'm a big believer in trying to give people specifics so they can visualize it, like they can see the numbers for themselves. And unfortunately, Jayapal hasn't put out actual numbers, but if we use Bernie's, I know I was thinking, now that I'm thinking about it, Friedman in his latest cost analysis and also UMass Perry, they have like suggestions of an 8% payroll tax and some other things. So I think Friedman's the payroll tax he's suggesting is too high because he's trying to do it almost all with a payroll tax. It's better to do a mix of things. So you keep your payroll tax in the single digits, like around 7 or 8%. And then I think it's a good idea to have a small income tax to capture people like my husband. I'm throwing my husband under the bus all the time, who isn't working, is retired. So there's a way to at least, because I think people want to contribute, especially people that are middle class, upper middle class, they want to pay something into the system. So if you have just a small income tax, and that's why I like Bernie's is 4% after the first 29,000. So, and then if you have those basic, tax parameters, you could make up a little chart and show, okay, people could look themselves up on the chart. I did this with the Affordable Care Act, and I would go out, to the street fairs and the parks and try to help people understand that they could get a silver plan for this much money. They could look their income up And then I have a chart where I could just stand there with this one sheet of paper, and people would be like, wow, you mean I could, and then I could tell them that they had qualified, a lot of them qualified for Medicaid and the Medicaid expansion. So, but it was a real nice interactive way that people could put themselves in the situation and visualize how it would benefit them.
Hello, Andrea. I have heard that every category of provider will be covered under single payer improved Medicare for all. But I don't often see all the CAM, what we used to call CAM providers, the complementary alternative medicine providers, listed as a benefit. And those are very popular with private plans. I know, non-Medicare private plans, people who are well employed and or wealthier have generous benefits in physical therapy, clinical massage therapy, acupuncture, naturopathic medicine, and that, I'm wondering if that might be one reason why people are nervous about ditching their private plans, because the really good plans do cover those things, and I don't see those being marketed very forthrightly. I don't see them listed like, I mean, not to pick on you, I love what you're doing, but when I see the benefits listed in print, I don't see the CAM benefits listed. Is that just because they don't want people to think? I mean, because those kinds of interventions are extremely efficacious. But I'm wondering if they think it's some sort of a negative marketing to list them or something. I think people might want to know that those are going to be included. Thank you.
Yeah, I'm not sure. I know physical therapy is, and certainly anything that's already covered by existing Medicare, you can be pretty sure that's going to make the cut, right? So people were asking me about chiropractic care, so I looked it up, and existing Medicare does cover some chiropractic, like for back issues. It won't cover massages, and it won't cover x-rays apparently in a chiropractor's office. I don't know if there's a lot of fraud at chiropractic office on x-rays, why you can't do x-ray. But so I tend to first go look and see if it's covered under existing Medicare, and then there's a pretty good chance that there's no reason why that wouldn't make the cut. But I'm not sure. I know Medicare was starting to do some things about looking into maybe including some acupuncture stuff. So those are going to be the things that we'll have to push, once we get to the bargaining table, to make sure that those things that we want in the plan. But I'm not sure about some of those other ones you mentioned. I'll have to look into that. We'll have to look at the actual text of Jayapal's bill, but it doesn't get real specific. It doesn't get real granular. But I know physical therapy is listed.
Yeah, it's political, but I watched the debate and I watched the following, and generally speaking, I'm undecided, but leaning towards Elizabeth. But don't you think that Elizabeth is hurting us, looking like an evasive politician by not dealing with the very issues that you've talked about tonight? It's not helping.
Yeah, because I think she doesn't, my opinion from watching her, I think she doesn't actually support single payer Medicare for all. I think she's an incrementalist. That's why she's having the problem. Because think about it, she's got a plan for everything, and yet on her website for months, she would not even use the word Medicare for all. And then finally, just a few weeks ago, she just added the word Medicare for all. And she's the one that said, if somebody's telling you that, that they can't do this and they can't do that, and they're equivocating, they're telling you something very important. They're telling you they're not going to fight for you. That was her quote, because I sent her that a few months ago. I took her quote and I sent it through her email, and I don't know if it was coincidence, but then all of a sudden, then that next debate, she was the one that raised her hand with Bernie and said that she wanted to get rid of private insurance. Because, she's telling you, to me, she's very Obama-esque on this issue, where if she really cared about it, she'd be singing it from the rooftop. She'd be putting it on her website. She'd be giving the details, right? And the more I see equivocation. Yeah.
Hi, I'm Larry.
Hi, Larry.
I volunteer for a local SHIP organization, if you're familiar with SHIP. It's a group of people that advise people on Medicare issues.
Okay. Is that like state health insurance program, SHIP, or?
Program? Yes. Yeah.
Okay.
Yeah. It's called Sheba here, but
Okay.
whatever.
Yeah.
And a couple of comments. One, you talked about dental insurance and things like that. Dental insurance, many of the Medicare Advantage plans do offer dental insurance benefits, and it sounds wonderful. In fact, some of them, it's not just restorative. They have a huge list of comprehensive processes they cover. But if you dig a little deeper, there's two problems with that. One, a very limited suite of dentists, long waiting lists, and they really only pay about $200 to $250 to spread amongst all of those comprehensive dental benefits. So it's, like you say, smoke and mirrors.
Yeah.
Yeah. The other thing is that many of the Medicare Advantage plans also cover acupuncture, naturopaths, massage therapists, things like that. It is indeed a big sales point for many people to swing towards Medicare Advantage. Thank you.
Yeah, thank you for that information. Like I said, sometimes to get the inside scoop of people that have more experience, actual, personal experience, or talk to people. But that's always been my impression and I've just been watching all the ads now that open enrollment started with the Medicare Advantage ads, and I see they use the word preventive dental, and then there's like an asterisk, right? But even going and buying your own individual dental plan, dental insurance is really kind of, dental insurance is really kind of BS insurance as far as I'm concerned. I mean, my husband and I, we each got a Delta dental plan because the one through his retiree, we were still paying $35 a month, but it was MetLife, and everybody we would go to, because we have our favorite dentist, right? They were always only Delta dental. So just to get that discount, that 25% discount by going in network was worth it, because we each pay $47 a month. The max the plan will pay out in a year is $1,000. So you're basically spending about $550 in premiums for a max benefit of $1,000. They'll pay 50% on crowns and whatnot. But the biggest benefit, especially with my husband, who seems to need a lot of dental work lately, is that you get that basically amounts to a 25% discount. So instead of our dentist charging us $1,300 for a crown, he has to charge $950, and then they pay, half of that until the $1,000 runs out. And dentistry is not something you can really wait on in most cases. That restorative dentistry, when you need a root canal, you need a root canal. You can't really wait around for a root canal. So, yeah, I think there are a lot of sort of just bright, shiny objects to suck people in. But the massage therapy and things. Now, of course, we do have the catch-all that with Medicare for All, both the bills, no one will be allowed to sell duplicative insurance. So that will pretty much wipe out most private insurance. But there is a clause that if something is not covered in the public plan, so it doesn't make the cut. So let's just say some of this massage therapy or homeopathy, theoretically, then a company could sell private insurance for that. But is it something that's an expensive enough item that there would be, an opportunity that people would buy insurance? Or would you just save your money and then pay out of pocket for that? I don't know how expensive those things are. But one of the things that is one of my pet peeves is when people say, oh, well, you'll still be able to buy insurance for like cosmetic surgery, like a facelift or a tummy tuck. Well, no, because they don't sell insurance for that now for a reason, because it's not medically necessary, and it's not, and it's completely elective. So it's not a service that lends itself to insurance, meaning people would sign up for the insurance, the cosmetic surgery insurance, pay a month of premium, and then go, okay, now I want my $8,000 facelift. And that's why they don't sell insurance for cosmetic surgery right now. They do what's called care credit, which is just financing it, paying over time, but it's not insurance. So I always like get frustrated with that argument because I think it just doesn't, again, I think it's people trying to find some role for private insurance. And I'm like, you know what? We don't need to punch holes in the floor. We don't need to find a role for them. There's really no role for rotary phones or T-squares or film for cameras, or we just need to let it go. But
Okay,
theoretically,
well,
somebody could do that.
thanks so much for everything that you've done tonight.
You're welcome. Thank you. It was a pleasure. Great question.
And there's a ton of information there, so people will have a chance to look at this either on your website or I think if it's okay, I'll put them on our PNHP website, the PDF file.
Yeah.
And as I mentioned, we do a video of this meeting tonight, and I'll hopefully edit that tonight and tomorrow and get it out in a blast with links sometime before Friday.
Okay, great. Thank you. Yeah, go to my website, connected.usa.com, click on Medicare, and then the link special one is where I put the PDF for this presentation. And at the end of the slides, I have this little script that I used if you want the details from that.
Well, it's so great to look at your slides, but you have to study them for a couple of minutes because there's so much information there. And if you don't believe it or whatever, you can go to the references on the bottom of the slide or check it out.
All well sourced.
Okay, so
thank you. Bye, everyone.
bye-bye.
Let's get it done.